Welcome to the fourth session of the maintrac online forum for this year 2024. This is in English. You know Professor Pachmann very well. She continues to lead the charges in the laboratory Pachmann, both clinically and from a research point of view. And today we have the topic of the clinical question for maintrac and stemtrac. We'll start off with a presentation.
Thank you very much, Joachim. We decided for this last presentation this year to talk about frequently asked questions and try to answer them. One of the frequently asked questions is, what is maintrac? Maintrac is a diagnostic method, and it's highly sensitive to detect circulating epithelial tumor cells. That's why we call them CETCs, but we add CTCs because this is the most frequently used term in the English-speaking countries. What we do is to monitor the course of disease, of cancer, with the help of a blood test. And we can also monitor the response to therapy. What are the possible applications of maintrac? Maintrac can be counted among the liquid biopsies. So it's directly from the blood. Therefore, it can be repeated as often as necessary and do in first line maintrac cell counting. So we count the number of cells over time. But in addition, we can also test therapeutic substances on the cells directly. And in some cases, it's necessary to know the characteristics of the tumor cells for therapy design. That's our therapy relevant tumor characteristics. And finally, we can also test for cells that are capable of dividing in vitro and forming tumor spheres. Often the question is what type of cancer we can use the maintrac cell test for. It is primarily used for solid epithelial tumors such as breast, lung, colorectal, prostate, pancreatic or ovarian cancer. With certain limitations, it can also be used for other types of cancer, like melanomas, sarcomas, and gliomas, but this is with restriction because not all of the cells in such tumors carry the epithelial antigen. We rely on the epithelial antigen to find the cells. When can the counting be applied? So this is mainly thought for monitoring the disease during the course of disease. Then we can assess the effectiveness of ongoing treatments, and we can assess the risk of recurrence after the end of treatment. So it provides a valuable tool for insights for personalized cancer treatment. The next question is, how often should maintrac cell counting be performed? We can count the cells before treatment to establish a baseline for comparison and initial base value. Then the numbers of cells during treatment can be counted, and this tells us about the effectiveness of the ongoing therapy. It means if the cell numbers decrease, then this is a sign that the current therapy is effective. And if the cell numbers increase, then adjustments may be necessary of the treatment. After treatment, many patients are afraid of recurrence, and we can see early after the completion of the treatment that the cell numbers re-increase, and this would be a sign that possibly the treatment should be started again or a new treatment started. In case of progression of the tumor and the resistance, we can evaluate how the tumor is responding to new treatments, or if the cell numbers do not respond, do not decrease, we can early detect the hint for resistance. What are the benefits of this cell counting? As I mentioned just before, the recurrences can be early detected, because if the cell numbers increase more than twofold, there's a high probability of recurrence of the cancer, even before clinical symptoms become apparent. We can monitor, as I also mentioned, the treatment, and the count, maintrac count, can indicate whether an ongoing treatment is effective. And this would require regular monitoring of the number of circulating tumor cells over the course of treatment. And as very important, this whole test is minimally invasive. It's a simple blood test, and the procedure is much less burdensome than a conventional biopsy. Also, it detects cells, and thus is a sort of biopsy. Very often we are asked whether there is a threshold for the circulating tumor cells. But since each patient is unique and each tumor has individual characteristics, there is no universally applicable reference value. So each case should be analyzed individually, the cells counted repeatedly, taking into account the specific medical history of the patient. And when interpreting these results, the dynamics of changes in the number of circulating tumor cells is much more important than a single measurement. We then, in our reports, interpret the number of CET-CTCs. And as you can see, that's how it is represented in our report. There is the number of EpCAM positive cells in the sample, which is 1 ml. And then it's calculated for 5 liters of blood. And in addition, we give estimation of the cell fragments. But it's very difficult to give a number for the cell fragments, because one cell can decay into numerous small fragments. So we just give an estimation. And 50 is a minimal number of circulating tumor cells. 50 to 100 we call minimally to slightly elevated. 150 to 400 is slightly elevated. 450 to 550 we call slightly to moderately elevated cell numbers. And 600 to 1,000 is a moderately elevated number, and above it's a highly or significantly elevated number of circulating tumor cells. This is just that you get an impression in the range of cells that we detect. How can these changes in cell numbers over time be interpreted? So if the cell number decrease, like in this example, the removal of the liver metastasis by surgery led to a decrease. So this suggests that there is either a good response to treatment, or sometimes if it's extended, it indicates that the patient remains in complete remission. But in this case, cell numbers increased and a new liver metastasis was detected. And subsequently, the treatment led to a decrease in cell numbers, but the liver metastasis did not shrink, because sometimes the cell numbers decrease before the metastasis shrinks. Then under paclitaxel, there was a slight increase, but repeatedly. The metastasis was still in remission, but then a new liver metastasis was detected, and upon paclitaxel weekly again, cell numbers decreased, but this obviously did not reach the metastasis. And that's something which we frequently see that the cell numbers in blood are the first to respond. If, like here, an increase in cell count occurs, this suggests that the therapy is not effective or that the disease is progressing, and it may also point to resistance to the current treatment, as it is during the paclitaxel weekly, the initial one. Can we use maintrac as a screening method when there is no cancer present? We do at the moment not recommend maintrac routinely as a general cancer screening method. It is rather specifically employed for monitoring known tumor and the development of a known tumor, and it's not at the moment applicable for general early detection without any prior diagnosis. So this is in contrast to other methods which claim that they can detect a tumor early. Another frequently asked question is, what is the difference between the circulating tumor cells and the circulating tumor DNA, which is called ctDNA? So what we detect in the blood, in the liquid biopsy, is intact cancer cells that have detached from the primary tumor and circulate in blood. Whereas ctDNA is just DNA fragments that originate from tumor cells. So we can detect really the living cells that have detached from the tumor. Again, what can we do with our test and what can ctDNA achieve? We have a direct analysis of living tumor cells, and these tumor cells can lead to metastasis formation. So in case the cell numbers increase, this is a sign that metastasis formation may be looming, and we can assess, as frequently already discussed, the response to therapy. In contrast, ctDNA allows mainly for detection of genetic mutations and alterations in the tumor DNA. It can also be used for assessment of treatment response and resistant mechanisms, and it can track tumor evolution, mutation, and changes in DNA over time. So both approaches are valuable for cancer diagnostic and therapy, but they are coming from different perspectives. The next question often is, what are the advantages of drug testing? We can directly on the tumor cells investigate the sensitivity of these cells to drugs with cytotoxic effects. So we can identify the most effective medications for the individual patients, as you can see on this display, where some of the substances are more effective on the circulating cells. They have a higher cytotoxic effect, and others are less effective. So this allows personalized treatment planning, maximization of treatment efficacy, and minimization of side effects for substances that are not cytotoxic, but which might kill the white blood cells and deteriorate the personal lifestyle. Often we are also asked which drugs can be tested. We can test the effect of all substances, including those of plant origin that have cytotoxic effects. On the other hand, the effect of antibodies, especially antibodies against PD-1 or the small molecules or otherwise antihormonal substances cannot directly be determined on the cells, but in these cases, monitoring of their effect via repeated CTC, CETC counts is important. Very often we are asked when this test should be performed. If a tumor should be treated with cytotoxic medications after the initial diagnosis, it would be helpful to start to test these substances before starting therapy, and especially when the guidelines allow for selection of different medications, these advantage or disadvantage of individual substances can be tested. In the metastatic situation, before starting a new therapy, it would be helpful to test the substances which are designed to be used for treatment. And in the case of disease progression during a current treatment, it can be tested whether these cells are still sensitive to the current treatment. Then we can also test for therapy-relevant tumor cell characteristics. Therapy-relevant tumor characteristics refer to the specific features of the tumor cells that are crucial for selecting the right therapy. These are, for example, hormone receptors on breast cancer, and even the androgen receptor is important for triple-negative breast cancers. Then we can test for growth factor receptors as HER2/neu amplification, EGFR or IGFR, or for prostate-associated markers like PSA and PSMA on the cells, not in serum. And PSMA can be especially important because there are now treatments using marked PSMA antibodies to treat the tumor. We can also look for proliferations and for immunomodulatory molecules in case of immunotherapy. And here is displayed a series of cells with the amplified HER2/neu receptor. Usually there should be 2 signals in each cell for 2 gene segments. And as you can see in some of the cells, there is a multiplicity of gene segments for the HER2/neu receptor. And this means it can be expressed more highly on the cell surface, and then the cells are more receptible to growth factors. The last was PD-L1 and B7-H3, and this is important for immunotherapy. So the question is, can immunotherapy be investigated on maintrac? Only in part, but the effect of the immunotherapy can be investigated indirectly with maintrac by maintrac cell counting. So we find very often a reduction in circulating tumor cells, which indicates a good response to immunotherapy. And as mentioned just before, PD-L1 can be tested. This is indirect. It tells us that there are cells which are sensitive to immune therapy, and expression can indicate a good response to immunotherapy. And then there is stemtrac. Stemtrac is an innovative diagnostic method for identifying and analyzing circulating tumor stem cells, CSC, in the blood. It aims to detect tumor stem cells that may play a key role in tumor development and metastasis. And these cells are often more resistant to conventional therapies. What are the advantages of stemtrac in cancer diagnosis and therapy? For prognosis, it can help us to estimate the tumor's aggressiveness. And if the stemtrac cultivated cells, the tumor stem cells, increase, this can provide indications that a tumor is going to recur before symptoms appear. And it can be used for therapy monitoring, because we can monitor the effectiveness of treatments on the cancer stem cells, on those cells that are capable to divide and drive the tumor growth. The question is, when should the stemtrac test be performed? The stemtrac can always be used in combination with maintrac to monitor the effectiveness of the remaining tumor burden. For example, after the initial diagnosis of a tumor to assess its aggressiveness, after completion of the therapy, to estimate the aggressiveness and the metastatic risk of the remaining tumor cells. In complete remission, when ETCs increase, then stemtrac may help to look whether this increase is due to proliferation of cells. And in case of disease progressions, when CETCs are low or undetectable, because they can lose their EPCAM during dedifferentiation, as typical for EMT, epithelial mesenchymal transition. And how often should the stemtrac test be performed? Well, the frequency depends on the individual situation of the patient and the course of the therapy. However, most often we recommend determining the number of circulating tumor cells every 6 to 12 months. Are there threshold values for the circulating tumor stem cells? Currently, there are no universally accepted threshold values for elevated circulating tumor stem cells, because each patient is unique and the tumor biology varies. But we have seen that a value above 350 ml of circulating tumor stem cells suggests an increased risk of metastasis development. Can drugs also be tested on tumor stem cells? Yes. If the patient has no circulating tumor cells, such as previously mentioned in cases with epithelial mesenchymal transition, we suggest that the determination of tumor stem cells and then perform drug testing on these developed tumor spheres. So now I am finished with the question which have been frequently posed to us, and I would like to ask you if you have any more questions.
Does the maintrac testing apply or not apply to CUP of cancer of unknown primary tumors? Is it useful to be used in that situation?
It can be contribute information as to whether, like, the tumor-associated markers are expressed on these cells, like, for example, PSA or PSMA or androgen receptor or estrogen receptor, or especially HER2/neu, then it helps closer define the source of the cells. But no, we cannot definitively make sure that the cells are coming from a certain source.
So what can be done? You can test for all the surface markers that are known, that
we can test. Yeah,
maybe helpful.
Yeah, that's what we can do to more closely get to know where the cells are coming from. But there are, for example, oropharyngeal tumors do not have special markers. Okay, so thank you for your attention, and you can always send us questions per email, and you can also call if you have urgent questions. Thank you.